A very good day to everyone. I'm Jeffrey Lim Zekang, a urologist from UC Malaya Medical Center, and it's a pleasure to talk about hormonal and systemic therapy in prostate cancer. This topic is supported by Ipsen, and we are really thankful to Ipsen for supporting our event, our ProteCap event. They have been a very strong supporter of us over the past few years. So thank you, Ipsen. The evaluation of intervention in prostate cancer, it starts with the foundation with ADT, androgen deprivation therapy. It can be performed either surgical or medical castration. Basically what it does is that it stuffs the field, it reduces the testosterone, it reduces the field for the growth of prostate cancer. This is the backbone. Next, we have receptor targeting, which is ARPI, androgen receptor antagonist. It blocks the pathway. We also have cytotoxic defense. This actually has been there even before ARPI era. Yeah, taxane chemotherapy. It actually destroyed the cells. And the frontier, the one that we are having right now, which is a precision oncology, a PARP inhibitor, immunotherapy, theranostics, and this actually exploits the molecular profile. We'll dive into it in a while. The castration threshold. When we look at papers, the historical target is less than 50 nanogram per deciliter for the testosterone level. However, at this modern era, the preferred modern target is less than 20 nanogram per deciliter. Why we say so is because the lower castrated level, the lower testosterone level, less than 20 nanogram, or even better, less than 10 nanogram per deciliter, they are directly associated with better clinical outcomes. Yeah. And ADT is still the backbone of metastatic prostate cancer treatment. However, the standard of castration level is now more aggressive, less than 20 nanogram per deciliter. First, I will talk about surgical castration. This is the most traditional way of castration. What we do is we give local anesthesia, we make an incision over the median raphe, and we remove both the testes that produce testosterone. Yeah, traditional way is simple, it's not expensive, and is highly effective. 12 hours, you will get the testosterone suppression. This is pretty rapid. However, it is irreversible, and you can't really perform an intermittent ADT for the patient if you would like to in the future. Next, touch about LH-RH agonist. As the name suggests, it is an agonist of LH receptors. So what it does is that it actually causes an overstimulation initially. Yeah, you can see the testosterone level. It causes initial stimulation. You release and flare of the testosterone, increased testosterone, and then there will be down regulation of the receptors, causing a castration level in a 2 to 4 weeks time. Agents that we are talking about before this, which is quite famous in the market, leuprolin, goserelin, triptorelin. Yeah, it can be given either monthly, 3 monthly, or 6 monthly, the one that we prefer at this current era. Yeah, you have to give it by injection. However, I'd like to talk about the flare. So when you give agonists, they have this initial testosterone surge. And this is particularly dangerous in a patient with heavy mets, prostate CA, because they will have severe pain over the bone area. They might have even urinary obstructions, and it might trigger a spinal cord compression, yeah, because of this flare, raised testosterone, before the castration level in 2 to 4 weeks time. Hence, lots of urologists, if they want to give LH-RH agonist at the first instance when they see the patient have to be covered with anti-androgen like bicalutamide for 1 to 2 weeks before initiation of LH-RH agonist, in order to prevent this flare upon injection of the agonist. Medical castration, we have talked about LH-RH agonist just now. We will now talk about LH-RH antagonist. The one in our market is Degarelix. given by injection, and something new, oral pill treatment is relugolix. The onset is immediate because it's antagonist, inhibit the receptors. There is no flare. And retrospective study has shown that it has potentially lower cardiovascular event. And the downside of IRH antagonist is you have to inject monthly. Patient have to come to you every month for the injection, as compared to IRH agonist where you can inject it 3 monthly or 6 monthly according to your preference. Yeah. So which one is better? In our clinical practice, in a patient who has a metastatic disease, especially heavily met prostate cancer, we will give and initiate the treatment with the Garelix first. Then we see back 1 month later, and then continue with a LHRH agonist like deferrelin as a 3 monthly injection, because patient wouldn't want to come to you monthly. They prefer to have a 3 monthly appointment rather than a monthly appointment. Unless the patient has a risk of cardiovascular event, then maybe you need to inject them monthly. Otherwise, 3 monthly injection or 6 monthly injection is the better options for us. So now we are looking at a graph, and I would like to talk about the lowest mean testosterone level during 9 months of treatment period were achieved in patients treated with deferrelin. Deferrelin is the one in orange, leuporin is the one in blue, and goserelin is the one in gray. We are looking at the axis here is the testosterone level, and we are looking at the x-axis, which is the duration of months. As you can see, deferrelin achieved a rapid onset of castration at 3 months, and it persists to be the lowest castration testosterone level at 6 and 9 months as well, as compared to the other LHRH agonists. So deferrelin was the most potent GnRH analog, and it achieved the lowest mean testosterone level 3 months, 6 months, 9 months. Another retrospective pool analysis, and low testosterone level with deferrelin are associated with improved overall survival in patients with advanced prostate cancer. So you can see this is what we're talking about. This axis is overall survival, and the axis X is on the timing, the days. The orange, you can see the overall survival is best in the patient who have a testosterone level that is less than 10 nanogram per deciliter. The green is the one that has a testosterone level of 10 to 20. Yeah, and another graph is 20 to 50. So what it's trying to say is that the testosterone level that is less than 10 nanogram per deciliter, it correlates with improved overall survival. Yeah, you can see the one in orange graph, they have a better overall survival as compared to a testosterone level that is 10 to 20 or more than 20 to 50. 96% of patients achieve low nadir testosterone level of less than 10 nanogram per deciliter, or the one that the unit that we use less than 0.315 nanomole per liter during treatment with deferrelin. And testosterone level that is less than 0.35 nanomole per liter or less than 10 nanogram per deciliter were associated with improved overall survival versus testosterone level of more than 10 nanogram per deciliter. And this is important because the better suppression of testosterone that is less than 10 nanogram per deciliter translate into a better overall survival. So you need to find a good agent in order to achieve a nadir testosterone of as low as possible, and preferentially less than 10 nanogram per deciliter. And this retrospective pool analysis shows that deferrelin can do this. Next, we talk about ARPI landscape. Yeah, we talk about abiraterone. It causes a synthesis blockage, as well as a novel AR antagonists like enza-APA and darolutamide. It actually blocks the receptors. Abiraterone, it blocks CYP17 enzymes, that synthesize androgen. ARPI targets androgen signaling more effectively than traditional therapies, and then now standard of care across multiple disease states, especially in MHSPC and MCRPC. NMR and MCRPC, you need to be careful. The abiraterone is not indicated in the patient with MCRPC. So a bit on the abiraterone, it actually causes the inhibition of CYP17 for adrenal synthesis of testosterone as well as intratumoral synthesis. It's a potent CYP17 inhibitor and it suppresses the androgen synthesis pathway outside the testis, and is deployed and used in a patient with MHSPC as well as MCRPC. However, this must be combined with prednisolone to prevent mineralocorticoid excess, because when the CYP17 is inhibited, it will cause hyperaldosteronism. Hence, you need to give steroids or prednisolone to actually counter this mineralocorticoid excess. If you are not careful, the patient will have a risk of hypertension because of hyponatremia, they have fluid retention, and they have hypokalemia, which is very troublesome to treat. Also, because you're adding on the prednisolone, there is a risk of hyperglycemia as well. So it's not so good in a patient with diabetes mellitus. Next, novel AR antagonists like enza-APA and darolutamide. It blocks androgen receptor nuclear translocation. It prevents downstream of AR DNA signaling and entirely halts the AR-driven tumor growth. Basically, what it means is that this androgen receptor antagonist, it prevents the transcription of the DNA. And the side effect, fatigue, fall, hypertension as well. So this is the ARPI toxicity and how do you select? Abiraterone is a synthesis inhibitor. The risk of mineralocorticoid excess is real. The risk of hypertension, hypokalemia, fluid retention, hyperglycemia is there as well. And it requires a systemic steroid pairing to prevent the complication of hyperaldosteronism. However, abiraterone now is available in a generic setting, and a lot of urologists and oncologists like to go for abiraterone because generic abiraterone is actually very economical at this era of time, although it comes with some side effect. Novel AR antagonists like enza-APA darolutamide, there's a risk of CNS as well as receptor effects, risk of fatigue, fall, and hypertension. Darolutamide has a distinction compared to other AR antagonists. It doesn't cross the blood-brain barrier, so the risk is much lesser, especially if you're really worried about the risk of seizure. However, even the generic enza that is available is still pretty pricey nowadays. Hence, now we are giving quite a lot of generic abiraterone for our patients. Next, we talk about this cytotoxic defense through taxane chemotherapy. The one that I'm talking about is docetaxel and cabazitaxel. Basically, how it acts is that microtubule stabilization inhibits the mitosis. It doesn't allow mitosis, cytotoxic. Taxane chemotherapy is actually there older than our ARPI, but I put ARPI first followed by chemo because chemo is less favored by patient. They prefer something like abiraterone or enza that they can take orally. Whenever they listen to chemo, then they will be scared, right? So, but still we have to touch about chemo because it's one of the most economical systemic treatment for patients with MHSPC as well as MCRPC. Second line chemo, cabazitaxel, and because it's chemo, the side effect profile, neutropenia, neurology issues, myopathy is there. Next, we talk about precision targeting, PARP inhibitor, like olaparib. It targets the DNA single-strand repair pathway in tumors that already lack double-strand repair capabilities, like for example, patient with BRCA mutation. So in order for you to give the patient for olaparib, BRCA testing is important and is required before you start the patient on olaparib. Yeah. Toxicity panel, anemia, fatigue, etc., etc. Next, we talk about precision targeting. For example, immune and AKT pathway. Immune checkpoint inhibitors is actually available in the market now, like pembrolizumab. It targets the PD-1 pathway. It is actually approved as a tumor agnostic indication, but strictly for patients with MSI-H and dMMR tumors. So it has a limited role. This pembro has limited role and for a very niche group of patients. Next, AKT inhibitors is not available and not approved yet, but it's emerging. It is ATP competitive inhibitors for patients with these genetic disorders. It's coming, probably in the next few years' time. Theranostic, the CE treat kind of paradigm treatment. First, you need to have a PSMA PET to identify the target. Only if the target lights up, you deploy the radioactive agents. The agents that we are talking about is radium-223, lutetium PSMA-177. Yeah. And lutetium PSMA-177 is more on MCRPC group of patients. And there must be a light up in the PSMA PET before you introduce a lutetium for the patient. Side effect, myelosuppression. And the core principles according to this EAU 2026 guideline, the backbone is still ADT. Yeah. And the thing that changed is the more aggressive castration level. We are looking at a testosterone suppression level less than 20 nanogram per deciliter, or the one that unit that we use less than 0.35. The unit that we use is the essential baseline for all advanced prostate cancer care. Because this has proven that the lower testosterone it is, the higher and the better overall survival, or what is translated is the better outcome the patient is. Right? Overall survival is one of the most important outcomes. So you have to hit hard, you have to pick the right agent to achieve that castration level. And the standard of care now is no more as monotherapy with ADT. In a patient with MHPC, ADT should be combined with either ARPI like ABI, ENZA, APA, darolutamide, or docetaxel chemotherapy, because this combination treatment is the standard of care. It improves the outcome and is the definitive standards in metastatic disease. No more giving ADT monotherapy in a metastatic prostate cancer unless in a certain group of frail patients. Yeah. In other patients that have a good life expectancy, good fitness level, combination therapy, ADT plus systemic treatment is a must. Also, we look at the frontier. This is an individualized precision. This is more works on the patient. They have to go for genetic testing. And PARP inhibitor, lutetium, pembro is coming into the pictures for selective patient. As this topic is supported by Defrelin, we are sharing this. So for you to get more information, the prescribing information, you can always scan this QR to get the prescribing information, and you can always ask if there's any question or you want to clarify. With that, I thank you everyone for your kind attention, and I see you during the Protecap meeting in Majestic Hotel.